Examination. Systemic examination. Systemic examination is important in case of vitreous hemorrhage to rule out the above mentioned causes. It is especially important in cases of vascular occlusion since there may be some cardiology or associated intracranial events that need immediate attention by a general physician. Similarly, it is not uncommon to discover signs of hematological disorder in patients with unexplained vitreous hemorrhage. It becomes more important when the disease or causation cannot be localized to the eye. Systemic examination associated bleeding disorders, you go for the petechiae, purpura, bruises, joint pain, suggestive of the bleeding disorders. So systemic examination in case of vitreous hemorrhage is important because it can give idea about the cause of the vitreous hemorrhage. For example, skin examination, general examination. There can be skin petechiae, purpura, ecchymosis, suggestive of bleeding diathesis, bleeding disorders. And there can be associated cardiovascular events because of the diabetes mellitus and hypertension and associated autoimmune disorders, systemic lupus erythematosus, that Miller rash and photosensitivity. There are so many things which are out of scope of this topic. That you can just go on finding out, but I don't have time to mention all these together here and include the photographs of them. So you can just think the causes and associated systemic diseases and why the systemic examination is important in case of vitreous hemorrhage. In diabetes there is neuropathy also. So central nervous system examination is important. It can be associated or there can be preceding stroke event. So CNS examination is important. There can be amaurosis fugax. So many things are there. Then ocular examination, visual acuity. Recording visual acuity of either eye is necessary. The status of the other eye often guides the management of plan. Usually normal eyeball, may be large in case of high myopia. High myopia, large eyeball can be seen. Proptosis may be in case of tumor. Axial in cavernous hemangioma. Proptosis, protrusion of the eyeball in case of the tumor, that is cavernous hemangioma, that is axial. Lead is usually normal. Then actually usually normal means there can be xanthelasma. Xanthelasma means these yellowish deposits, yellowish lesions on the lid, on the nasal side of the lids, on the upper lid and the lower lid, which are made up of like because of the deposition of the cholesterol. So lipid profile is important. So lid examination can give idea about the hypertension, hypercholesterolemia. The cause of which is hemorrhage, CRVO and all. So conjunctiva, multiple BRVO mainly, because CRVO it does cause, but BRVO is one of the main causes of the NVE and NVD than CRVO. Conjunctiva, multiple hemorrhages in conjunctiva may be there. Conjunctival microvascular abnormalities in sickle cell disease, the comma sign. is pathognomic, but its pathogenesis remains obscure. In such cases, corkscrew vessels are seen. Similarly, in heart disease, conjunctiva may reveal vascular tortuosity or in rare cases, bulbar telangiectasia. Now, common signs, sickle cell disease. What is sickle cell disease? It is a hemoglobin disorder where there is a beta globin uh, chain. There is a point mutation. The abnormal hemoglobin synthesis is there, and that in hypoxic conditions, these hemoglobins can come together. The sickling of the hemoglobins, the red cells, they come together. That is known as sickling phenomenon. They can obstruct the vessels and they can involve so many systems. And one of the causes of the proliferative diabetic retinopathy. You can go through that video on the vitreous haemorrhage, which is present on the inside of ophthalmology. They have given so many differential diagnosis of vitreous hemorrhage with pictures and the explanation, and it will really help you to understand and remember these things in a better way. Like sickle cell disease, there are fan-shaped vessels and salmon patch hemorrhage is there. So you go through these videos that I have suggested. One video at least, vitreous hemorrhage on the inside of ophthalmology. So in sickle cell disease, there is a common sign that is a pathognomic, but its pathogenesis remains obscure. Then corkscrew vessels are seen on the conjunctiva. Tortuosity of the vessels can be seen in cases of heart disease. In rare cases, there can be bulbar telangiectasia. So conjunctival vessels can give idea about the underlying cause of the vitreous hemorrhage. Common sign in sickle cell anemia, hemoglobin disorder, sickling phenomenon, RBC coming together, blocking the vessels. That is sickle cell disease, involvement of the many systems. Then right-sided heart failure. It can uh, raise the venous pressure, and there can be vascular tortuosity, conjunctival vascular tortuosity, and then there can be bulbar telangiectasia. Bulbar telangiectasia. Telangiectasia means tele means end or entire, complete. Angio means vessel, and ectasia means dilatation. Dilatation of the vessels, capillary or venules, small vessels. Telangiectasia can be seen on the conjunctiva. So this conjunctival examination can give idea about the cause of the vitreous hemorrhage. The cornea uh, may be large and corneal thinning may be there in myopes. Cornea. So see, if it is a diabetes, there can be neurotrophic keratitis because of the trigeminal D because of the peripheral neuropathy, the ophthalmic branch of the trigeminal nerve. It's dendritic pattern that supply the cornea. The dendritic pattern of the nerves that supply the cornea can get affected. It can be very neurotrophic also. So it's very important. And the cornea in myopes, it can be large, corneal thinning can be present, and even neurotrophic ulcers can be present in the autoimmune disorders also. Now sclera. Scleral thinning may be there, blue sclera in collagen vascular diseases. Blue sclera, Ehlers-Danlos syndrome, osteogenesis imperfecta. Scleral thinning can be present, which are the collagen vascular diseases. anterior chamber, keratic precipitates. In uveitis, anterior chamber examination is important. Even the neovascular glaucoma, angle vascularization, and angle closure glaucoma associated with the vascular events. Glaucoma associated with the vascular events, intraocular pressure. Increasing the intraocular pressure can be the cause of the vascular events. Keratic precipitates, cell flare may be present in the inflammatory diseases. Deep anterior chamber is seen in high myopic cases. There may be the sign of angle closure glaucoma. Iris, iridodialysis, neovascularization of the iris, or NVA. Neovascularization of the angle may be there. This is extremely important. It is prognostic and diagnostic. Iris, iridodialysis, traumatic cases, iridodialysis can be present. Then iridodonisis can be present. Neovascularization of the iris and angle in proliferative diabetic retinopathy in CRVO. So it has got prognostic and diagnostic importance. Pupil, presence of relative afferent pupillary defect. If there is large retinal detachment, large macular lesion, retinal vascular occlusion, optic nerve disease, retinal detachment. So relative afferent pupillary defect can be present in such situations, and even ARP can be present, Urgell-Robertson's pupil, in which accommodation reflex is present, but on light reflex, the pupil doesn't constrict. So it's because of those peripheral nerves which remain intact. In diabetes, what peripheral pupillary nerves supplying the parasympathetic nerves supplying the pupil, sphincter muscles. These are affected last, and the central motor nerves supplied by the smaller vessels in diabetes. These are affected even in hypertension. So we get this ARP condition, Urgell-Robertson pupil. So that can be present in diabetes. That can be associated with the proliferative diabetic retinopathy. That is also one of the things that you should look for. Then intraocular pressure, and intraocular pressure less than 9 millimeters of the mercury or more than 20 millimeters of the mercury. These things need to be investigated and explained. Hypotonic globe would suggest retinal detachment. If there is a retinal detachment, then hypotonic globe, that is less than 9 millimeters of the mercury, IOP. There can be wound leak and open globe injury occurred at obvious. Raised IOP could be due to neovascular glaucoma, hemolytic glaucoma, corticosteroid usage, or tumor invasion under conditions of vitreous hemorrhage. Intraocular pressure, one of the complications of the vitreous hemorrhage, ghost cell glaucoma. Now, what is ghost cell? Ghost cell, it is any epithelial cell which has the cellular outline intact but the nucleus is absent. That is ghost cell. So, we can see when the RBC, uh, when the cellular outline is intact but no nucleus. Anyways, So the cellular outline is intact, but the cell is dead. So that is the host cell. And when the hemoglobin is taken out of this RBC, when it is degenerated and the cellular outline is intact, it has that. So it gets that spherical shape, and it gets stuck in the tubercular meshwork, and it leads to increase in the intraocular pressure. It is called as ghost cell glaucoma. And then another thing, there can be neovascularization. Neovascular glaucoma can be there. Accompanying retinal detachment can be there. So hypotonic globe can be seen in vitreous hemorrhage. So that is the importance of the intraocular pressure. Corticosteroid usage in the uveitic conditions. Tumor invasion under conditions of vitreous hemorrhage. Gonioscopy. Neovascularization of angle can be seen in cases of the proliferative diabetic retinopathy. Angle recession or cyclodialysis may be there in case of the blunt trauma. Angle recession and cyclodialysis. Lanes. Following points must be noted: subluxation, dislocation, zonular dialysis, phacodonesis, and traumatic cataract. Presence of all these points towards the trauma as the underlying cause of vitreous hemorrhage. Even in diabetes, there can be early cataractogenesis in diabetes, and traumatic cataract can be there, or there is a trauma to the lens and damage to the zonular dialysis. There can be phacodonesis, the lens moves because the support is lost or support is less. There can be subluxation, dislocation. Even in the collagen vascular diseases, there can be subluxation and dislocation of these lenses. Anterior, because of the weak zonals. Anterior vitreous, presence of vitreous pigment or Schaffer's sign, commonly seen in presence of retinal detachment, but rarely also in cases of trauma. Presence of RBCs or hemosiderin pigments can be typically there. Importantly, retrolental cells may also be seen in their presence, however, is not specific for uveitis. So, anterior vitreous pigments or Schaffer's sign, commonly seen in the presence of retinal detachment, but are also seen in case of the trauma. So, we don't see vitreous pigments normally on the slit lamp examination, but when we see the vitreous pigments, it is called a Schaffer's sign. When these are seen in the retinal detachment, these pigments are also seen in case of the trauma. Presence of the RBCs or hemosiderin pigments can be typically there. Importantly, retrolental cells may also be seen. Their presence, however, is not specific for uveitis. Now, fundus examination. Posterior vitreous detachment can cause vitreous hemorrhage. If posterior vitreous detachment is there, scleral depression is mandatory to rule out a peripheral retinal break. So, if there is a posterior vitreous detachment is seen, Then on fundus examination, and if it is seen, then you go for the scleral depression method to see if there is any peripheral retinal break. It is important to remember that an acute PVD with VH has an up to 70% incidence of the retinal tears. So if there is acute PVD and vitreous hemorrhage, in 70% of the cases there is a retinal tear. Compared to low incidence in acute PVD without VH, if there is acute PVD, acute posterior vitreous detachment without VH, if there is posterior vitreous detachment and there is a VH, then in 70% chance is there that there is a retinal tear. So scleral indentation is very important to see, look for any peripheral retinal break. And if there is acute PVD but there is no VH, it's less likely that there is a retinal tear. Other findings to look for includes NVE, NVD, obviously weight ARMD, diabetic retinopathy, familial exudative vitreoretinopathy. Now what is familial exudative vitreoretinopathy? Familial exudative vitreoretinopathy means the child is not, the fundus, the periphery of the fundus is not vascularized. It is seen in retinopathy of prematurity also, but it is seen in premature babies. And while the familial exudative vitreoretinopathy, the periphery of the retina is not vascularized and the babies are not premature. These are full-term babies with normal body weight. So that is familial exudative vitreoretinopathy. Look for that because there can be NVD, NVE and vitreous hemorrhage. Then retinopathy of prematurity is there. Obviously retinopathy of prematurity, premature baby, so the peripheral retina is not vascularized yet. Then retinal vasculitis. Retinal vasculitis, Eales disease is there, and there are so many other diseases, autoimmune diseases, in which the retinal vessels have ongoing inflammation in the vessel wall. Signs of trauma, proliferative sickle cell retinopathy, this fan-shaped LVE you can see in sickle cell retinopathy. Venous occlusion and Salmon hemorrhage, Salmon patch. Venous occlusion, retinal macroaneurysm, choroidal melanoma and angioma. Presence of fresh red hemorrhage mixed with old bleed is suggestive of recurrent bleeding. So there is a old bleed and there is a fresh red hemorrhage. It is indicative of recurrent bleeding. It is seen in Eales disease. It can be seen in proliferative diabetic retinopathy and bleeding tendencies, bleeding diathesis. So recurrent bleeding indicates retinal neovasculopathy. In old hemorrhage, one should look for presence of fibrotic clots. Old hemorrhage, look for fibrotic clots. Presence of diffuse whitish opacity should indicate possibility of other causes of media opacity. If there is diffuse whitish opacity, then look for other possibilities, other causes of media opacity rather than the blood in the vitreous cavity. Specific fundus features of individual diseases may be there.